Thank you for, I just like that it's always, thank you, appreciate it. I like it, and that's fun.
check, 1, 2, check, check, 1, 2, check, 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 1, 2, check, 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 1, 2, check, 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 1, 2, check, 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 1, 2, check.
Yep. 1, 2. One, two. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. Yep.
welcome back those who are in the hall. We hope others will be joining us. I think they call this the graveyard session, do they? The one after lunch. So Danny, you've got a big responsibility. If you find anybody dozing off, just point them out. Be like, Nevin, open your eyes. Anyway, you're all welcome. We're going to do a session now, which we switched around with the National Health Insurance session. And this one's on scalable health informatics and digital health innovations, experiences and learnings, sponsored by Smart Applications. And in this session, we've got Pharm Access with Nicole. Happy that Nicole could join us again. Lovely to see you again. We've got Smart and Judy. Apparently her voice is gone, so now we've got Peace. Then we've got Clinic Pesa with Mr. Crispinus Onyancha. Is that right, Crispinus? And then we've also got Tech Care for All East Africa Chief, Mr. Benson Chuma. And the session is going to be ably moderated by Dr. Danny Mutembe, the Vice Chairperson of Rwanda Healthcare Federation. So Danny, let me invite you and your panelists, please. And we look forward to a lively session. I just want to say after this session, we will be breaking into parallel sessions. So when this finishes, we're running about half an hour late. So I imagine, so we're now at maybe 3:30, about 3:30 to 4. We'll be dividing into two parallel sessions, one of which will be here, will be in the role of public-private partnerships and strengthening access to quality PHC services by PATH. And the other is CAFU Hall, Knowledge Management Success, sponsored by AMREF. And I'm told that the family planning people should aim for going to the AMREF one. So I will say more about that later. Thanks.
Thank you, Ian. Good afternoon, everyone. I hope you enjoyed your lunch. Please try to keep awake. If you feel like you're sleepy, we'll get tennis balls and we'll start sharing in the room. So my name is Danny Mutembe. I'm the moderator for this session. I believe that this session is going to be very, very interesting. It talks about scalable health informatics and digital health innovations. So without further ado, I would like to invite our speakers. I'll start with our first speaker, Nicole Speaker from Pharm Access International. She's the CEO. Peace Uor, who's representing Smart Applications. She's stepping in for Judy Mgoya, who's the country manager. Crispinus Onyancha from Clinic Pesa. He is the Chief Executive Officer. And last but not the least, Benson Chuma, who is the CEO of Tech Care for All East Africa. Welcome. As you can see, it's a perfectly gender balanced panel. And coming from Rwanda, I'm extremely proud. Let me start with Nicole Speaker. Kindly introduce yourself, talk about what Pharm Access does. And I believe that will also be interesting to hear about how can digital technology transform and accelerate universal health coverage.
Thank you, Danny, and thanks to the organizers for first of all inviting me. It's so amazing. This is one of my favorite conferences, and to see everybody again in the same room after many years of lockdowns is, yeah, I almost feel like it's my birthday, and everybody has shown up for the party. So really amazing. I also really want to thank you for accommodating me in rescheduling this session. I was the cause of that because of a board meeting that I couldn't reschedule, which was my formal excuse, but actually it was because I'm always afraid to speak after Prof. Kama on the stage. So I figured I'd be safer with the lunch in between, and hopefully we will be engaging as a panel. So my name is Nicole Speaker. I'm the CEO of Pharm Access. We're an international organization that works in healthcare sector development to ensure that we can develop inclusive health markets. That means that we have to make sure that there are good quality services, but we also need to make sure that people are financially protected and are able, through financial protection, to go to a healthcare facility and avoid out-of-pocket payments. Private sector is a very important role to play for a few reasons, not only because 50% of the hospital and healthcare services are provided by private healthcare providers. And we heard that this morning, many great examples, but also a lot of the initiatives are actually private sector. And I think what we were talking about today in this session is that there's a great opportunity there. It means that there are opportunities to invest in private sector development, from issuing loans to healthcare facilities, something that we do, but also investing into technology solutions that can help bring especially lower income groups towards healthcare financing solutions that are affordable and targeted and effective. And to that purpose, we actually started a company called CarePay, and I'll talk about that a little bit more later on, that in Kenya is already connected 4.5 million people to these healthcare financing solutions. Now, the reason why I'm advocating for this, and I'm really looking forward to the discussion today, is that we will all be talking about the huge opportunity of digitalization that can really drive in terms of telemedicine, remote care, data and technology, drive the way forward. But we need to get to action now. And I'm looking forward to hearing the examples. There's great examples. How do we together scale them and create an enabling environment so that they can be scaled rapidly, so that not only the hospitals and the patients are African, but the tech solutions that we are offering are also, as much as possible, African and homegrown. So I look forward to the discussion. Thank you very much.
Thank you so much. So our next panelist is Peace War. Please introduce Smart Applications Uganda.
Thank you so much, Danny. I'm really, really glad to be in this space. And I'd like to thank the organizers of this specific event, the Uganda Healthcare Federation, and the other stakeholders who are really, really, really happy to be here. So my name is Peace War, and I'm standing in for Judy Mugoya, our country manager, and I'm the business development manager at Smart Applications Uganda. I'd like to talk just a little bit about Smart. Smart is an ICT solutions company, and we are passionate about health. So that's why we came into the healthcare space to develop digital solutions that help resolve different challenges within the medical industry. Smart currently, we have presence within 11 African countries, with our headquarters being in Nairobi. And we are working hand in hand with medical insurance companies, community health insurance schemes, and a number of healthcare facilities in providing solutions that are helping medical insured members, helping medical facilities in terms of automating their medical processes. So currently the solution is serving over 1.2 million members across the 11 countries in which we have presence. And particularly in Uganda, the solution is installed in over 700 medical facilities, serving over 250 medical insured members within Uganda. Yeah, so we're really glad to be part of this innovation. We're really glad that we are seeing a change within the medical industry. And that's our passion. That's what we basically stand for. And yeah, why not? We can't wait to really be part of this great discussion. Thank you.
Brilliant. Thank you so much, Peace. So our next speaker is Crispin. Please introduce Clinic Pesa.
Thank you so much. Good afternoon, ladies and gentlemen. I'm glad to be here today. My name is Onyencha Crispinus. I'm CEO at Clinic Pesa. At Clinic Pesa, what we do, we provide access to healthcare financing, but through something that is a little bit different from insurance. We provide it through a medical mobile bank, a saving account, where someone can be able to save from their work as they work, like say, for example, a market vendor is working on a day-to-day, they're able to keep aside some little money, and then they can be able to move to the next door healthcare center. And in the event they do not have enough at the point of paying for their medical bill, we come through for them and we're able to give them a medical loan top-up. Now, thinking about aspects of scale, we looked at how best do we be able to scale such a model. And through a very good partnership with MTN, we managed to push out the solution and targeting, of course, the mass majority that do not have health insurance. And today we are already serving over 370,000 customers. And the number is growing by the day. And we're working with close to 1,838 healthcare centers. These include some hospitals, pharmacies, clinics, medical centers. Now, of course, we're striving so hard to be able to grow the customer base in order to balance the traffic for our healthcare centers and also bring more value to the healthcare space. Thank you.
Thank you, Crispinus. Benson, the CEO of TC4A, that is Take Care for All.
Thank you, Danny. Afternoon. As I heard, my name is Benson Chuma. I am running an organization called Take Care for All. But more important is our platform, which is called the Medical Learning Hub, which just exists to support lifelong learning for healthcare professionals. We believe that technology has a critical role that can be used and harnessed to support and make it easier for healthcare professionals to access, to digest, to go through various forms of content. I am based in Nairobi. Happy to be here. I haven't been in Kampala for a long time. And we have operations that run from Nairobi. We have our presence here in Uganda. We are doing some projects supporting e-learning for one of the hospitals, one of the large hospitals in Gulu, that's St. Mary's Hospital, Lachor. We're in Senegal and a couple of other West African countries, and really happy to be here.
Thank you, Benson. This session really touches on the core theme of this event. I have the feeling that will make other session participants and panelists jealous. Let me start with asking Nicole about digital technology. Digital technology transformation and its acceleration of universal health coverage. You give us your thoughts and also examples, please.
Great, thanks so much. Let me start by making a bold statement. I think unless we use digital technology, UHC is not possible anywhere, not just on the African continent. We need to start embracing digital technology. Now, let me give you a few reasons why. Often when we think about technology, we think about, here's an app that can help with data collection. And sure, data collection is important. We should be reporting faster, government should be having much more real-time data. I'm not arguing that those things are not important, but they're not true digitalization. You're just making a digital version of what was probably already a functioning process, just a very slow process. Now, the biggest challenge with universal healthcare coverage is that in its current structure, if it is functioning to the degree it's functioning, it's a contractual relationship between the payer, which is typically the government or a national insurance company or donor, and a healthcare provider who gets paid for the services that they deliver. Now, out of this structure, the most important participant is forgotten, and that's the actual patient. The patient in this triangulation has to assume that when he or she goes to a healthcare facility, that the services that they are entitled to, because somebody set aside the money to pay for that, whether it's the government paying for your pregnancy care or the Gates Foundation paying for your family planning services or your auntie paying for your health insurance services, you have to assume that that entitlement is actually there. But there's no way of really checking that you are entitled for doing that. It also means that the transaction costs of engaging patients onto UHC models are expensive. You have to re-enroll them every year. People have to go and submit their applications. And especially if you're an informal sector or very low income group, that's just the hassle of doing that is extremely difficult. And sometimes you don't have the paperwork to do it. Digitalization can really help make that change. What we've done with PharmAccess, we've actually partnered with Safaricom, which is the big telco in Kenya. I'm sure all of you are familiar with them. And we started a company that actually developed a three-way platform called M-TIBA. So instead of M-Pesa that you're all familiar with, where you can send money to it and at very low transaction costs, you reach that. The point with healthcare is that usually the money comes from somewhere else. You don't pay for it directly. So we're engaging patients, payers, and healthcare providers. And now you can put the entitlement to the healthcare services in the hands of the individual patient, who can then go to a healthcare facility, access services. Healthcare facility can submit a claim and be paid in real time. Now, all of a sudden, it means patient empowerment. They know what they're entitled to. Extremely lower transaction costs because you're using a digital infrastructure that in all of the countries that are represented here today is already there. You don't need to put telephone poles or anything like that in structure. But importantly, you also can start doing something that we need to discuss when it comes to UHC. The fragmentation of healthcare financing is just too big. And we need to start thinking about how do we pool insurance premiums, how do we pool, big programs like PEPFAR and TB and malaria treatment, and a lot of local money that is already being spent every day, because I'm sure many of you, as we speak, are contributing to family members and friends to take care of their healthcare services. You can now all start pooling this and give people a basic healthcare package. Now, another very important effect of this, and we have made estimates, we think that we can do twice as much money, twice as much healthcare with just the same amount of money that is already in the healthcare system. Now think about that. Every day we have discussions, how do we get people to co-pay? How do we bring more money on board? How do we allocate more budgets from the various organizations and governments to bring into healthcare? And we need to have that discussion. But imagine if you could do twice as much with the same amount of money that is available today. You could actually help twice as many people, and that would make a significant impact. And while you are digitalizing all of that, that same information could have done a few things. First of all, we would have been able to manage this COVID outbreak that kept us all apart for the past year a lot sooner and a lot quicker, because we would have seen what the damaging effect was much earlier with much more inside information on the ground. But also we would have been able to make this pandemic given a much more African response. We were talking about this during lunchtime, and a lot of the responses that were implemented here on the ground were based on the data and information that was taking place in Europe and the United States. And looking back, I think we can all agree that this outbreak was very different in different parts of the world and definitely didn't need a differential response. And as of now, we still don't understand what are the effectiveness of vaccines, how do they relate to risk groups, what should be a good vaccination strategy if we move forward again. And data and technology can work with this information provision. So it's not just an app data collection, it's really transforming how health systems are delivered. Thank you.
Thank you so much. Please, a round of applause for Nicole. This is brilliant. Peace. Where are we here now? And what have we achieved for the past few years in digital innovation? In Uganda, yes, but in the East African region, as a whole.
Thank you, Danny. Over the years, we've noticed quite a tremendous improvement when it comes to technology adoption. I'll give a brief background on where we started basing on our experience. In the past, we had challenges when you look at the medical industry, medical sector. For example, there was too much paperwork that was being done. Look at the interactions between hospitals, administrators, who in this case I could call the medical insurers. So there is a challenge, there's too much bulk of paperwork that is being interchanged. And how long does it take, for example, for the scheme administrator to receive this information from wherever it is coming from? We've seen cases in terms of management of member benefits. It has been a challenge in the past, where people are not even aware the medical insured member is not empowered enough to know how much am I covered for as a member, which medical facilities am I entitled to access, which benefits am I entitled to, because with medical insurance, I believe there are quite a number of exclusions. You find that medical facilities probably could not be aware of that, or they are aware, but the member is not aware of that actually certain services are not covered, that they're not supposed to access certain medical facilities. And then at the end of it all, we're talking about data. How is this data being managed? Loads and loads of data. Are we making sense out of this data? And if we look at the data as well, what does the data tell us in terms of predictive analytics? For example, what are the trends telling us in terms of patient visits, in terms of frequently diagnosed diseases, in terms of traffic in different medical facilities? So we've seen improvements in terms of adoption of systems that are helping to reveal all this information and making access to healthcare much easier. A casing scenario, I'll look at some of the technologies that have come up in terms of mobile applications that are basically empowering the member in terms of knowing how much am I covered for, which medical facilities am I entitled to visit. So it helps them in terms of making informed decisions. They also feel part of the process. You know, in most cases, the member who is the end user is almost let out of the process, and they feel like it's a transaction insurance. I have to use all my money that I'm allocated. It doesn't matter, but they have to know the value of the card they're holding. Smart, we provide medical cards, so I'll relate to that. So they have to know the value of their policy. So we've seen such applications. In the advent of COVID-19, as a technology company, it was a big hit for us. Trying to see now, there is no movement. Access is restricted. How best are we going to deliver services? Looking at the fact that we're partnering with medical insurance companies, medical facilities, how are we going to offer the same support as before the pandemic? So there were some innovative ways. We partnered with some of the telemedicine providers within the industry. In Uganda, for example, we had some partnerships with telemedicine. So we managed to provide that platform to ensure that there is continuity in terms of real capture of claims, in terms of transmission of that data to the insurers, to ensure that there is an improved turnaround time in terms of payment, so there is no lag. And as a member also, you are empowered knowing that I can access telemedicine where I am, whichever time, and there is a platform that has already been provided. So it was quite, a big change for us. And then we're also looking at analytics. We've seen in the past that as the years go by, data analytics is something that we cannot do without platforms. Those platforms, we can't do away with them. We need platforms that are going to help us in terms of knowing information, making sense out of the huge amounts of data, real-time dashboards that are telling us what exactly is happening So that is very important. And we've seen that within the different East African countries and also the different other countries in our scenario where we have presence, and it's really working. So in terms of digitization, it's something we can do without in this era. Previously, it was looked at as a by the way, and I believe even now we have people who are still looking at it as something that is not really relevant. We approach medical facilities now and then you're trying to tell them you need to uptake this solution that is going to help you in terms of knowing how many patients you're serving, automating your processes, but they still don't see the need. So why is all that there? There's something to do with the mindset. Most of us have seen the need, but there's still a lot more that we need to do out there in terms of sensitization on the importance of digital solutions.
I think she deserves a round of applause too. And believe me, it's also good for you. It helps blood circulation, most probably, but digestion will be faster. Crispiness. Please tell us, I'm sure you have so much to tell us about the success, but if you could touch on the challenges of your financing model, that would be very interesting for the audience to know.
Okay, so it's a good question. The challenges in trying to issue affordable financing for healthcare. Healthcare is still a space competing with the other sectors. The same financing that is being offered for other industries is the same financing that is being offered for healthcare. That means you're actually meeting the same cost. Now you're going to offer the same amount of, you're going to be offering this same pushing the same cost to the patients, someone who is actually sick. So the challenge that you'll be facing is how to balance on pushing out, let's say, for example, if you want to extend someone a medical credit, let's say, for example, to meet their cost of care, you have to, it's going to be a challenge to be able to keep that cost low, because where you're getting the capital from, the cost is a little bit high. You're getting it from the normal commercial banks. You're getting it from the normal debt providers who are going to cost it at market rate. And because this is not something that you're actually lending for business, you're lending for someone to be able to get medical treatment, it becomes a bit of a challenge. And then the other aspect is with regards to, of course, available capital. Now, when you look at companies that come up, let's say, for example, a good example, we who are in this same space, and you want to get such kind of capital, commercial banks are going to need collateral. You're going to need all sorts of securities. Our securities have not, the way we collateralize this capital has not yet evolved as compared to what is abroad. What we're getting locally, typically, we are looking at securities in form of a prime land somewhere in town that you can be able to use to secure such kind of a debt. But then out there, someone would look at the ratio of equity, how the company is capitalized, the clientele base, the market opportunity, and then based on that, they actually be able to extend to you credit and or capital, and it's easy for you to continuously finance and extend this affordable financing to many people who actually need it. So still, when you look at the healthcare centers, the clinics, hospitals, all these are players that are actually cut out in terms of financing. So we are only looking at this side of the patient being able to pay and receive quality care. But there's an aspect of the provider who is actually providing the care to the patient. So they are struggling to get affordable capital as well to be able to enhance the services that they're actually extending to the customers, to be able to buy equipments, to be able to also be able to access medical supplies so that they can actually be able to extend better services to the patients. Now, the same principle of types of collateral will apply. I think the sector will change with time, whereby people might banks and financial players might start looking at other forms of collateral to be able to allow such players to actually access affordable capital so that they can be able to improve these sectors. Because when you look at the biggest percentage of contributors in the healthcare space, we're not looking at the big hospitals. There are so many small clinics, medical centers. Actually, when you move in the outcasts, you find that the people who provide the first level of care are actually what we call the drugstore, the drug shops. You know, those are the people who would give, who would actually sell the medicine to the people who are living around that community. And normally they would call them as doctor, you know, they label them as Msao, you know. So they will walk to this person and present their problem. Now they would assume that the diagnosis given to them is equivalent to that of a doctor. And so they will be able to pay for this at that point and be able to receive this care. So when you're looking at how all these are actually capitalized, how they acquire the financing, can they be able to acquire a formal commercial bank loan? Typically, the answer is no, because their transactions, first of all, are even not documented. They're not digital transactions that have proof of how much money are you making and how much money are you spending. So there is quite a bit of a challenge around all that that I think needs to be addressed to be able to close these gaps of financing.
Brilliant. If you don't clap your hands, then you're not gender sensitive. Thank you. So, Benson, what is the potential of technology in supporting capacity building efforts for health professionals in Africa? We're going now slightly, beyond East Africa, for Africa.
Thank you. I think first is just the first bit of what's the potential of technology. I think everyone here is agreeable that it's huge. From our experience, it's not just purely a technology question. It's not just purely a platform question. It's really about how do you deploy technology that is able to address the needs of the context, and the context at times is different. So it's not just purely, even when you talk about digital health, it's not just purely a question of technology. It's also context to happen. We're just coming from in the country in Kenya, just right from an election. To give an example that was heavily technology driven. I had a friend, I will not think can be my guest, or you can guess, who could not understand how are we able to download, the question of how are you downloading results, like how people download songs. So it just shows how technology can really be deployed. To the question of capacity building, it's so how we've, and I'll give an example of how we've done it is understood what are really the needs of healthcare professionals. And one big need we saw is continuous medical education. And healthcare professionals have at times have to travel long distances to access content, and health medical field is rapidly changing. So we know the potential is huge, and we know that we can train as many people with technology you become unlimited. So for example, in East Africa, we have about, on the Medical Learning Hub, we have about 30,000 healthcare professionals who are subscribed to us, and they cut across from frontline community healthcare workers to specialists. And back to the potential. So when we implemented it, it was really demand driven and just understanding the context. So for example, we work with hospitals where they still everyday hospitals do their CMEs, internal CMEs, and a lot of them, especially with COVID, have moved online, but they sort of are standalone events, and there is no tracking of, say, Dr. Benson has attended this session, but do we know whether he's attended the next session? Can we understand his needs? So we work with hospitals where we tell them, we will provide you a platform. We have a freemium model where we say for free, you will use our platform, and your doctors, your nurses coming in will be logging in, we'll create profiles for them, and they will then be able to access they will then continue your CMEs, and you can do very many fantastic things. For example, do needs assessment, you can send quizzes to them, you can get info and feedback. On the other hand, we then talk to pharmaceutical companies who are looking for these people working in hospitals, and we tell them, hey, rather than having to chase each and every prescriber or each and every person that you want to inform and train about, say, your products or the latest advances, why not just come and be part of this platform whereby in 10 minutes you can talk to, say, for example, we are working with a chain that has 60 outlets in Kenya, and you can talk to them in 10 minutes, and you are able to share with them about what you wanted to tell them, and you can probably get feedback. You can do assessments. You can do in pharma, they call it, they talk of e-consents, they talk of market intelligence, etc. So you can see that's how we can use technology in a very innovative way and be able to be sustainable, as well as educate healthcare professionals and really at the end of the day have an impact. So it's huge. The potential is huge. It's a matter of how we innovatively deploy it and use it.
Thank you, Benson. I know that the EHP also has developed a platform, East African Health Platform, for trainings and CPE from vision, etc. But let me come back to Nicole, and now we're just going to gear 2 and try to be a bit fast in the interest of this session. How can digital transformation enable new private sector development in healthcare?
Thanks, Danny. I think it relates to the comments that we heard earlier. I think there's twofold opportunity. First of all, we already heard the challenges of healthcare facilities accessing healthcare financing, especially for the lower end of the market, those small healthcare facilities just around the corner where most people will go to for their first healthcare needs. We've actually, with Farm Access Group, we started, I think now 13 years ago, the medical credit funds. That is a special fund that is blended financing that helps healthcare facilities achieve loans through directly or through banks. Now, in the beginning, we always worked through banks, and we took the first loss, and we thought all these banks are now going to lend to these healthcare facilities. But it was still difficult. Banks somehow don't like lending to healthcare facilities, even though doctors, it's the most reliable portfolio. It's the best portfolio there. It's just a market where they're sometimes hesitant about. Digitalization helped achieve a big role there because we developed a product that runs on mobile money. So it runs on M-Pesa, it runs on M-TIBA. And now healthcare facilities, instead of going to a bank and demonstrating their collateral, which is sometimes also difficult, especially if you're in the slums, you may not even own the building that you are using. All of a sudden, you can submit your digital transactions, and you are able to issue these loans. And we've seen repeat loans over and over again. In Kenya, it replaced almost completely our regular loans. And importantly, it really opens up, especially that market of women entrepreneurs, who are many of the facilities are run by women, and yet they often are unable to access the loans because the collateral is still in the name of their husbands, and that's a whole another topic to discuss. But this is a solution until we fix it permanently, of course. So that is a real transformation that is able to bring this financing much closer and much lower transaction cost. I think the second and even more strategic driver is the use of this technology that we just talked about. We're sitting here with a group of people, and all of these initiatives are African initiative, African homegrown solutions, but they need blended financing. And what we see is that a lot of the tech investments that are out there, people want to invest in tech, but nowadays they want to get the return and their impact, and please, in 3 years. And this tech hype needs time. It's going to happen on the African continent. It is happening on the African continent because my colleagues here are talking about it. I've been talking about it, but we need investments that are long-term, that are patient, that are blended, so that also donor money starts changing its role from financing your typical, all the important stuff that we do, but also in addition now start taking the risk of setting up these companies, building the capacity. I think the third part is where we're only starting to understand what this digital technology is doing. And we've been hearing our colleagues talk about data. Now, I'm from Europe. We messed up this data thing big time, right? Because we never did anything. And then a few American companies became so rich that millionaires, they used to build university hospitals when they were very rich. And now they build rockets to fly to Mars. So that tells you that there's something seriously wrong with this whole model, right? So, and we messed that up in Europe. So first of all, let me tell you as a European, please don't make that same mistake. What we did is we started regulating data and protecting it. And we forgot that the value is there to be made. We haven't figured this out. There's going to be a huge opportunity once this data comes out there that you're going to have products and services that run on this data. From science to technology to diagnostics to telemedicine to remote care models. And that's going to open up investments that will add value. Now we're not only talking about using the money that is there, actually creating value from the information that comes from African people, bringing that back to the African people that need it. And I think that is a revolution that is already happening there. But if we don't start talking about how do we bring investment money into the continent that is patient and that is not looking for that unicorn big return in 3 years and then everybody becomes a millionaire, and also sets a system in place where African people are empowered to decide together what they want to do with the data. Don't let somebody else do that, and don't just protect it. Think together how you can keep that value in your country and help create more healthcare for everyone. So huge opportunities knocking on our door, but the urgency is there and we need to start doing this and not just talking about it. Thanks.
Thank you. Thank you so much. So peace. What we mentioned, we talked about the challenges, right? And I think Nicole mentioned the challenges in misusing, I would say that way, data or misusing the focus, the initial focus. What are the challenges that you see that many healthcare systems still face while taking on digital health strategy?
Thank you.
Yeah, go ahead.
Yeah, thank you.
The gentleman, and I insist on the word gentleman at the back, insisted that you speak louder. They find it faded.
Thank you, Danny. I hope I'm clearer. Okay.
Gentleman at the back, okay, you can hear? Yeah, that's it, okay.
Okay. In our experience, one of the things that we're seeing is the mindset in terms of technology adoption. And that would be my first point. Mindset, I'll break it into terms in terms of trust. Let me bring trust into this. We have this thing that we don't trust locally developed systems. I just don't know why. And in most cases, we find that there are people who are they're opting to adopt solutions that are open source solutions because they feel they are cheaper. And then we are looking at this information and we are wondering at the end of the day, what is the security that is guaranteed with these solutions that we are all running after? That has been one of the major challenges that we're noticing as a technology company. And then we're also seeing some of the constant challenges that are being mentioned in terms of when we're fronting out solutions, that is in terms of the investment it takes. People look at technology as something that is a cost, that is a heavy cost burden on them. But we are forgetting that in the long run, this is an investment that will actually help us in terms of driving efficiency. So that cost mindset, the first thing is, what is the cost that is associated with this technology? So those are some of the challenges. Then I'm also seeing policies. Do we really have actual policies that are guiding, for example, health facilities that in terms of technology adoption? If it is something that is made mandatory, for example, and is there support that is being given to them in terms of actually adoption of this technology? That goes back to my earlier points that I mentioned in terms of sensitization, that technology in this era is not just a luxury, for example, it's a need, because we're dealing with data and we need to know what drives our businesses. We need to know what will our businesses be tomorrow using the information that we have. And also that brings me to a point that I feel that the value for information is not looked at as a big thing. We don't value information because actually this information that we are looking at, we are failing to invest in is what could actually change our organizations and make us bigger in the future. Because if we have control over this information and we know, for example, if we look at the medical industry, if, for example, you know the traffic, if that is being driven to your medical facility, if you know that diseases that are constantly being diagnosed within your medical facility, it helps in terms of investment into the right tools that is actually going to help you in terms of one, bringing efficiency into the services that you're offering, and also shortening the time for the services that you're offering, service delivery, actually making it easier. So that is what I would, yeah.
Thank you. Thank you so much. Thank you. I saw Crispinus nodding. Maybe you want to add something to that and maybe touch also on the lessons learned, from these challenges with COVID, but also, answering if we are ready for the next pandemic. I'm touching wood. I hope it's not coming soon.
Okay, thank you so much. So adding to the challenges, of course, when you look at the aspects of data, currently, of course, looking at Uganda, the regulation is actually picking up. They always say the regulators will find the innovators already in the space, and they will come and regulate around or regulate the innovation, So when you look at the space already, we have the law that protects with regards to data, regulating the systems. But when you look at the small players, typically when it comes to the regulation, in most cases, they would be having the capacity to be able to check the boxes of the regulation, And yet, when you go to the small facilities, they actually serve a lot of patients, you know, but their data is never captured. Their data is never captured. They do not have a lot of insights into the trends of their healthcare centers. Yet this would have highly contributed to the value of the healthcare facility. As they say, data is the new gold mine, you know. So without that data alone can give the facility a lot of opportunities that they are actually not having a sight to today. So that being, of course, one of the major challenges, it's going to take it's going to take a lot for the small players to be able to put in place systems to be able to capture that, unless maybe there are innovations, of course, that will emerge to give the small players, the small facilities, the small clinics, the tools and systems to have insights into their data. And then they will be able to favorably compete with the big players. They will be able to see clear insights into the trends of their businesses, and they will be able to make better decisions on how on the next strategies they should be able to implement into their businesses as well. And this also on the side of that's why, of course, when you look at nowadays mobile money solutions for payments like Clinic Pesa are actually taking up shape. That means typically in the transaction space, you would be having people have some bit of record of how many patients they've actually treated, how much money they are making. And with this, they can walk to any financial institution and say, look, I have my records here that show how much I actually make. So if you give me access to credit of this much, I can be able to finance it back. You know, I can be able to service it. So the aspect of data and how to handle it, typically it's an aspect of allowing the technology companies to come in and provide innovative solutions that these small players will be able to use to better their businesses. You know, with regards to, of course, the aspect of cost to technology being looked at as a major challenge, because technology, implementing the technology yourself is a bit costly. So if you get a player who has at the back of the mindset that the person I'm targeting needs this service to better his business or to grow his business, but I need to provide this same service at a very minimal cost and target the aspects, the unit economics of numbers, such that they focus on getting the value from the unit economics of numbers rather than the high costs extended to them. Yeah.
Thank you. Benson, how can different organizations and health sector stakeholders leverage technology to engage with health professionals in Africa? I think it touches a bit of the training. Yes, the floor is yours.
Thank you. I think I like the question that it's not just purely training, it's more of there is an aspect of engaging. I think the first is really understanding, we call it the user journey. So if, let's say, for example, you mentioned that there is, mentioned about COVID, there you talk of the same and outbreaks of Ebola, and you want to say, for example, rapidly, very quickly influence or guide how your health professionals behave. I think technology could be a very instrumental tool. And one way of doing it is what I'm calling the user journey, just understanding, let's say, Dr. Benson Chuma, how does he get his content? So, and where does he get his content from? And what's the best way to get a hold of him? So, for example, we've learned that health professionals are big on Facebook, and they have groups where they discuss, well, there'll be a lot of things to discuss about themselves, but you will find, for example, they will discuss hard cases, they will discuss different things, academic. So you could use social media to engage with the HCPs. You could use platforms like LinkedIn, and we do this and we're able to target, like if you want to, for the specialized one, you can figure out, I want my epidemiologist or my infectious disease people to know that I have this event, and you can really drill down and target them. So I think social media is one way of engaging and interacting with the health professionals. Back a bit to e-learning, I think it's important to, so there is the general things that you must have if you're engaging with them online. So for example, CPDs are important. So for example, for that reason, we are listed by the UMPDs, the Uganda Medical Council, as well as the allied health professionals to offer that. But I think it's a matter of also taking it to the next level where you say, okay, fine, about areas that have limited connectivity, and we start thinking of, today when I'm in here, I have some Wi-Fi, or even if I was in the hospital, I'll have some Wi-Fi, and I'll be able, so we have a creating an app where people can download, and when they are offline and they get home, then they can watch the content, and later on it becomes synced, so they can carry the content on their phone, and you can, when they get back online, you can track the progress. Again, you can take it to the next level, engaging them, and you decide, you know what, I want to include what we call gamification. And health professionals are very competitive. I think it's just how medical training is a bit. So you create groups of people and you say, I have your content on this outbreak. I would want you to do these quizzes. I want you to finish very fast, or I would want you to go through the content. And then if we are 20 of us, I'll show you who has finished fast. I'll show you how far they are going. Because again, the problem with online learning, I'm sure all of us here have a course that we started and we never finished, or we probably just did the first 20 or first 15 minutes, pretty much everybody. So what if you bring that aspect of a community and gamification, where you can see, oh, so-and-so seems to be ahead of me, has done 3 courses. I am at my first one, has gone to the next level, and you start giving them badges, you start giving them virtual treats and awards. So that's what we are thinking, that's what we are doing, and really thinking about that the engagement is multifaceted and it's multiple points, but also leveraging on the community aspect of it.
Thank you, Benson. We'll go to the floor. We have a few minutes for a few questions. Please ask very short questions directed to the panelists, our experts here. Be as brief as possible. I see one hand there. Then we have 2. Well, we'll look at the time. We'll just first start with the 3 questions. I see 4 questions. Can you circulate the mic, please? Oh, okay.
Thank you. Thank you. My name is Robert Waswa. My concern is concerning patient data protection. Is a patient's privacy secure in digital health as more and more data is being stored online? Don't we need to have some measures in place to ensure that digital health remains secure for everyone? Thank you.
Thank you. Maybe we'll answer one question at a time. I think that's better. That's best to address as much as we can. So maybe we'll start with Nicole. I think she chipped on that earlier. I think it's data security, and yeah, protection.
Yeah, extremely important point. And I think we're seeing that many countries are working on this. Kenya, I think it was a few months ago, passed a data protection law that is actually quite good. It was inspired a lot by the European GDPR law that I think most of you are familiar with. Now, there's always a gap between the law and what is happening on the ground. But we see, for example, with our tech company, we get audits to check our data security and data protection. And those are serious and very good audits. So I think it's something that needs to be taken very seriously, that has to be put in place and demonstrate protection. But as I was saying earlier, data is happening. And be careful that you don't only act out of fear. It's an important topic, but don't only act out of fear. Also think about what that same data can do in terms of opportunity.
Thank you. Thank you. Maybe do you want to add something briefly, quickly? I think the panel is satisfied. Question number 2. I think there was a hand that was raised quickly there. Let's just be fair. And then we'll come back to, yeah. Oh, okay.
Thank you very much. My name is Johnson Andinda. My question goes to the lady of the smart card. I work as a program manager at Health Partners Uganda. We promote increased access to health care through cooperative health insurance, where majority of the underserved are also supposed to access care. And this is a low-cost model where people pay very little premiums. And one of the challenges facilities which offer these health care services face is identifying their members. And I know going digital would be the thing, but if premiums are really very low, and I believe some of the cards are so expensive that the premiums, how would we advise us to help our partners go digital without really feeling to raise premiums?
Thank you. Thank you. That's for peace.
Thank you so much for that question. And I'm actually not surprised that it came out at such a platform. Thank you for asking that. One of the things that we've done as SMART, we've put into consideration how are we going to work with insurance companies? How are we going to work together with community-based health insurance schemes to make sure that we also support their initiatives? Indeed, one of the challenges that we've been seeing them facing is in terms of patient access at the different medical service providers. That ranges from identification, claims management, registration of members within the fields. That's for the field staff who are registering members within the different communities. So we got so passionate about this, and we've partnered with actually some of the community-based insurance schemes to ensure that their members are catered for. So with this model, we are using, should I call it a cardless system? So putting into consideration that this is for the vulnerable, we are calling them the vulnerable because they're not able to afford, probably they could say the cost of the smart card is high. And we're also considering the premiums. How best then can we support them to ensure that digitization is also part of their processes, that we're also automating their processes in terms of having visibility on data that is being captured at the medical facilities. Member identification is being done. Payments in terms of turnaround time, payments from the scheme administrators to the medical facilities is being done on real time. So we've come in to support them through this initiative, and we would also be looking forward to work hand in hand with other organizations that have the same model to support the community initiatives. We've worked with some organizations. I think I can mention a few. We have Safe for Health Uganda. We've worked with Uganda Protestant Medical Bureau, and the initiatives are still ongoing to to ensure that those who are at the grassroots are also using technology to solve some of their challenges in terms of collection of premiums, identification of members, which is key because I believe the biggest challenge that is being faced is that is it the bona fide member that is actually accessing services, and we provided for them a biometric system that enables the capture of that information right from the point of accessing services, going through the transmission of claims to the scheme administrators. We've also implemented scheme rules. For example, there is copay, and we've seen that is something that is common within the community health insurance schemes in terms of managing control or control to access, restriction to access within different facilities. That is being done. We have what we call regulations in terms of how many times we access services, and all that has been implemented through the platform that we provided to them. And I think this is not something new. I believe we can actually work with the majority of the community health insurance schemes. Yeah.
Thank you. We have time for one more question over there. And if the question is short, yes.
I thought I was doing pretty good with 4.5 million subscribers, but I'll need to check with you maybe later who I missed. So I think in terms of market penetration, we are doing quite good. 4.5 million people in Kenya have mobile M-TIBA on their mobile phone. Over 3,500 healthcare facilities have this on their phone. Now, mind you, this is the platform itself. Now it's like running railroad tracks. You need trains to run on the railroad tracks to actually start using the services. So up to now, we've been partnering with private sector insurances, most notably AAR and Jubilee are offering the services on their platform. But we've also been very fortunate to work with big partners such as Child Investment Fund Foundation and Milk for Mothers, who are offering care bundles specifically for pregnant women, that we're able to target those women and offer services and use the data and technology to really get the women to interact with their healthcare providers and have a good quality and predictable in cost care journey. So that platform has already reached 60,000 pregnancies. And then the last, I think most important comment has been the adoption of the M-TIBA platform in Kisumu County, where we are partnering with the county and with the National Health Insurance Fund to help develop the Marwa County Insurance Scheme, which is basically a group purchasing mechanism for NHIF cover, but where M-TIBA helps the county to enroll people, interact with the people, but also importantly identify the indigents where they are paying for their services, because we can all recognize that if you're an indigent, you will never be able to co-pay for that services, and there is a solidarity mechanism. So the county has set up a fund that those who can pay can then contribute to those who cannot pay, and they contribute as a county. So I beg to disagree with you. I think we've done pretty good in the market penetration. What we have not done is reached the scale where we really include as much as possible, especially the lower end of the market. And I think this is where we're still, and this is why we're so excited about the Kisumu partnership, because it really offers an opportunity at relatively, impactful scale, but still in a way where you can bring the partners and really model this to really understand how do you make the technology built in a sustainable business model that can make UHC work. Now, whenever you start building the first service of something, Had the first light bulb probably cost $100,000 to make, and now the light bulbs are everywhere. The first electric car was extremely expensive, but now there are electric cars everywhere. So I think the first time we're setting up a digital infrastructure, the costs are always a little bit higher. And that's also the point why I was advocating earlier, that these type of early investments really should be de-risked. And I purposely say de-risked instead of donor funded, because I think that is the purpose of that money. Otherwise it will stay a donor program forever. But if you de-risk that early investment, you allow a county like Kisumu County to get used to what a digital technology is and then have a model for replication. So I think we are at steps of digital technology really transforming the market. What we need to figure out together is how do we get companies like CarePay, but also companies to invest in this and have these long-term commitments in public-private partnerships together, rather than being dependent on programs that we heard one of the earlier speakers talk about, tend to start and stop after 2 years. But happy to discuss more later on over a drink. Thanks.
This was very exciting, and fortunately, that's all the time we have. I see Prof. Camarogo wanted to say something, but we have the chair here.
I think we'll have to move on because it's not fair to the next session. Right. And we're ready.
So you've seen our panelists here, Nicole Speaker from Pharmaxis, Peace War from Smart Applications, Crispinus Onyansha, Benson Chuma. Thank you very much. One round of applause. That was very exciting. Thank you.
And thank you, Danny, for ably chairing the session. Do you want your notebook back? Mobile phone? So we're going to break into parallel sessions now in the main room. Everybody's leaving their personal possessions behind here. In the main room, we've got the main hall, the role of public-private partnerships and strengthening access to quality and equitable PHC services, which is by PATH. And in the CAFU hall, which is downstairs, we have knowledge management success, sponsored by AMREF. And I'm told the family planning, Grace said the family planning people should head downstairs, okay? So if we can split ourselves up now, and this will be the last session of the day for most of us. This will be an hour and a half or so. It's quite a few speakers in these sessions. And after that, at about 6, the federations, those who know that they're parts of the federations, will be having another meeting after that. Otherwise, we'll reconvene again tomorrow morning at 7:30. Yeah, at 7:30. So we should get deliberations in this final session. And thank you very much to this digital. I wonder actually if somehow, Kama, do you not stay in Kisumu? Is that not your country? So I think Kama is. Okay, so we need to now reorganize ourselves. So we're going downstairs, go down, and those staying here.
Good afternoon, ladies and gentlemen. I didn't hear any responses. Good afternoon, ladies and gentlemen. Some people. Is that enough? We want to jump a bit? We are good? Professor Rogo is leading us. Okay, let's take our seats. Let's take our seats. We'll be excited to have everybody stay with us. This is the session that is facilitated by TAS, and we are going to be discussing private partnerships for primary health care. Countries. We work in 70 countries around the world, but specifically in the East Africa region, we work in 4 countries, that is Uganda, Kenya, Tanzania, and the DRC. But if you want to know more about what we are doing, because this is not enough, I want you to see the work, the innovations that we have come up with, the work we are doing in HIV, what we are doing in vaccines and immunization. We do have a booth downstairs, so please pass by and see all the innovations that some of the innovations that PATH has come up with that we are implementing in some of the countries, especially in Uganda here. So before I go any further, I just want to provide a bit of framing for this conversation that we are going to have this afternoon. I know it's late, but the next 60 minutes are going to be very interesting. Now, we understand that, recent increases in global health resources and challenges have prompted new models and innovations for solving global health problems. So that means we need to leverage creative partnerships like those between the public and the private sector in order to, respond to the global health challenges that we are seeing, especially challenges like COVID-19 that we all understand so well, and so many that we know are still going to come in terms of whether they are pandemics or there will be epidemics. Now, PATH, since 1977, so we've been here for some time, before maybe some people in this room were born, we have successfully partnered with many organizations, including dozens of commercial firms within the health sector, where we collaborate to develop specific products, develop policies, advocate for financing models that can help to overcome global health challenges, especially for people who are living in low resource settings. So for us being here today, like I said, it's the first time that we are participating here. It is really an opportunity to connect and to engage with key healthcare stakeholders in the East Africa region on primary health care. Of course, in line with what we believe in as an institution, we will have a colleague that will be speaking to us about what our vision for primary health care is as an institution, but also the work that we are doing in terms of advocating for equitable policies and sustainable financing for the health sector in countries where we work. In terms of overall objectives, the overall session objective, we want to explore the role of public-private partnerships in strengthening access to equitable and quality PHC services. But also, specifically, we want to explore the role that private sector plays in primary health care. I'll be referring to it as PHC, policy development and implementation. We also specifically want to discuss this afternoon the models of public-private partnerships that are currently being utilized to increase access to PHC services. And finally, we want to highlight innovative financing mechanisms that provide opportunities for public-private partnerships. So those are our three specific objectives. Now, to help us interrogate this important topic, like I said, we have an hour, but we are going to start with someone that is going to help us provide the overall framing. So, you know, the conversation, you understand how all the pieces come together. So we do have a keynote speaker that will be speaking to us shortly. But we also have an interesting panel with people from the East Africa region. We have speakers from Kenya, Uganda, and Ethiopia. So you really don't want to miss that. Please stay where you are. And because we want to make this a conversation, so it's not a monologue. I'm not the only one going to be speaking. This is a conversation. So we have looked at ways of involving you. So at some point, we are going to use technology. People were talking about technology here. So we are going to leverage technology to hear from you. We shall have a Menti session that will make it really interactive so you can provide some insights into the topic that we are discussing. But also, finally, we shall have a fireside chat that will be moderated by a top-notch journalist that some of you, if you're Ugandan, that you might know very well, Madam Mildred Tuhaise will help us moderate our fireside chat so that we can all share and hear stories from across our region. So without much further ado, I want to introduce our keynote speaker for this session. He is a health policy and financing specialist. He has a lot of experience leading programs and creating interventions for public and private sector clients in the US, but also in sub-Saharan Africa. His interests are in designing innovative demand and supply side financing interventions that increase financial risk protection, they reduce out-of-pocket expenditure, that is something we are all complaining about, and they increase health system financing. He is PATH's Deputy Director for Primary Health Care. Please join me in welcoming our keynote speaker, Dr. Muyiwa Tegbe. I hope he's online. Yes, Dr. Muyiwa, over to you.
Good afternoon, good morning, everyone. Can you hear me?
If you're speaking, we can't hear you yet. In designing innovative demand and supply side financing interventions that increase financial risk protection, they reduce out-of-pocket expenditure. That is something we are all complaining about, and they increase health system financing. He is PATH's Deputy Director for Primary Health. Do people ever cringe when they listen to their own voice? Speaker, Dr. Muyiwa. So I'm cringing up here. I hope he's online. Yes,
Hello,
Dr. Muyiwa.
Can you hear me? Can you hear me?
Yes, we can.
Okay, I think there's a little bit of a delay.
In designing innovative demand and supply side financing interventions that increase financial risk protection, they reduce out-of-pocket expenditure. That is something we are all complaining about, and they increase health system financing. He is PATH's Deputy Director for Primary Health. Do people ever cringe when they listen to their own voice? Dr. Muyiwa, I'm cringing up here. I hope he's online. Yes,
Hello,
Dr. Muyiwa.
Can you hear me? Can you hear me?
Yes, we can.
Okay, I think there's a little bit of a
hear you
delay.
yet.
I think there is a loop. Can you hear me now?
Financing interventions that increase financial risk protection, they reduce out-of-pocket expenditure. That is something we are all complaining about, and they increase
Hello? Hello, can you hear me? Hello, can you hear me?
Yes. Yes, we can.
Okay, I think I will just go ahead. There is a little bit of a delay on my end, and I think I'll just go ahead. Good morning, good afternoon, everyone. And thank you so much for the kind words, Esther, and really great to see you. I think I consider Uganda my second home right now. I've traveled to Uganda at least twice this year, so I'm really happy to see some kind faces there. So really just want to set the tone, as it were, for this discussion, this very important discussion, and actually discuss when we're talking about primary health care. I think there isn't any way to reframe it but to say primary health care is very, very important as we talk about improving health outcomes, improving equity, improving health security, and also when we talk about the cost efficiency and effectiveness of interventions. This is a well-known fact. This is well established, and it has been well established by all bodies of knowledge across the world. But unfortunately, we still see that primary healthcare is grossly underfunded. And grossly underfunded, we have operated primary healthcare in a very siloed manner. We have not actually tried to, up until recently, try to think about actually how do we prioritize who primary healthcare services are directed to. So you can go to the next slide, Bill. Who primary healthcare services are directed at. So the good thing about it is that and for this conversation, I will just want us to zero in on what the opportunities are.
Okay, I found a way. Okay, so I think we are having some challenges with our technology. Dr. Muiwa, I'm going to request that you hold on just a bit. Let us start with our panel discussion. So allow me to welcome my colleague. She is our Policy and Advocacy Country Lead at PATH in Kenya. She's an ardent advocate who is currently leading PATH's work on the continuum of care for maternal, newborn and child health and primary health care as well at the national level, but also at the subnational level. She also supports a lot of the regional immunization advocacy work and capacity building efforts for PATH in Francophone countries. So she's French speaking as well. Just so I should mention, please allow me to invite my colleague, Melissa Wanda, to moderate the panel session. A hand clap will be good. You're welcome, Melissa.
That didn't work as it was planned. Good evening, or is it afternoon? All protocols observed. My name is Melissa Wanda, and I'm happy to see that the room is still full. So, ladies and gentlemen, the conversation we'll be having today has set a good pace for what we're going to discuss this afternoon. We are just narrowing down to primary healthcare. So every conversation that has happened has led us to this session. And I'm going to introduce to you a panel that is full of individuals with illustrious and very rich careers around private-public partnerships and primary healthcare. Ladies and gentlemen, allow me to introduce a public health specialist with both academic and field experience in health promotions and disease prevention. Currently, he is the head of health promotions and health education, as well as health communication department at the Ministry of Health, Uganda. He is also a champion of strengthening primary health care for universal health coverage. He represents the 14 East African countries to the Public Health Community, Community of Practice Technical Committee for Africa, hosted by CDC. He has authored several papers in PHC related areas, and especially community health strengthening. Ladies and gentlemen, please welcome Dr. Richard Kavanda. Doc, you're welcome. Thank you. So the next panelist is an accomplished health system specialist currently working at the Kenya Ministry of Health as the public-private partnership or collaboration lead. She boasts of championing public-private collaboration initiatives in the ministry through spearheading development of the first PPP collaboration strategy and a training resource guide in Kenya. Ladies and gentlemen, please welcome Maureen Kangi. Our next panelist, and please, I will tell you his name, but then it's pronounced differently in his country. So he leads 3 private healthcare facilities as the CEO of Acacia Memorial General Hospital, as a director planning of Universal Health Plant, and a managing director of HEMA Advanced Diagnostic Laboratory, which is the first ISO certified privately owned institution in Ethiopia. Currently, he's serving as the president of Ethiopian Employers Federation and Secretary General of Ethiopian Healthcare Federation. Ladies and gentlemen, I introduce you to David Mogis. You can call him Dawit. Dawit, thank you. And last but not least, is someone with over 14 years of deep understanding and experience in the health sector through working with Kenyan government and commercial private sector institutions, as well as non-profit organizations. He has extensive experience in East Africa's health system and the landscape as a whole, and is currently involved in private sector leadership as a director of the Kenya Healthcare Federation. And he is also a member of the Kenya Medical Association, our association's national governing body. Ladies and gentlemen, please welcome Dr. Walter Obita. Okay. So in Kenya, we usually sing the East Africa community anthem. And don't worry, I'm not going to ask us to sing it. I know that will be a test to our Kiswahili. So, and we do this because we are a community, right? This is a learning ground. We learn from each other. We share resources, we leverage on expertise. Beyond trade, there's so much that we are able to learn from each other. And so, in our first conversation, and this is a question to Dr. Kavanda and Maureen. What is the model of private-public partnership in your country? And how has the model supported the accessibility and quality of primary healthcare services in your country? While we are talking about that, please point out the proof points that are there to show that these models actually work so that we can learn from them. So for the person who has a functional microphone, we can start with Dr. Kavanda.
Thank you, moderator. And regards to the PATH team for having organized this interesting session, also on PHC and why we need to have some detailed discussions with our colleagues who are into the private health practice across board, and also to be able to see the contribution of the private sector in mitigating issues related to primary health care, and how best we can leverage on the available social networks that we have within our countries to be able to advance the PHC agenda. I would say that if you look at our policy frameworks in the country, in Uganda, and how they actually support the PHC agenda, and how best the private health care providers are best suited in there, it's a bit more diverse. I would say that what we have in Uganda is more of a service cooperative agreement that which we do implement with a number of service providers within the private sector and other key institutions that actually support our PHC advancements. Most of it is more in the area of legislative analysis, which we do as government, but of course also to be able to bring reforms on board and harmonization of what we do and what the private sector does, to be able to develop a good niche that enables healthcare service delivery at a community level. And maybe also the other interesting bit would be in line with the provider networks that we have seen and the advancements that we have seen, especially by the private sector, and the policies and strategies that we have and guidelines and standards that have been set in place to ensure that these networks grow and implementation is actually in line with the legislative frameworks that have been set up by government. Yeah.
Thank you, Dr. Kavanda. Maureen, would you like to take it on?
Good evening, everyone. All protocols observed. I will begin by sharing the journey of how Kenya redirected its focus on public-private partnerships and also collaborations. So when Kenya launched the Big Four agenda and included universal healthcare in it, the Ministry of Health on behalf of government sat down and asked yourself, do we have enough resources to help the government achieve the UHC agenda? And the answer was not quite. So the government asked itself, what measures or what other avenues can we leverage on to help us achieve this agenda? The private sector has been there, and not much has been maybe happening between the two sectors, but the government decided and resorted to focusing more on the private sector to assist achieve the UHC agenda. Looking at the health markets in Kenya, both the public and private account for almost half-half. So they realized they cannot work without each other. They needed to work together. So they looked at the Public-Private Partnership Act, and they realized it's mostly transactional, one-off, and it favors more infrastructural projects than what is expected in the health sector, that is service delivery. So what's next? What next does the government do to ensure that it achieves its UHC agenda? And that is how the Ministry of Health decided to develop a public-private collaboration strategy that customizes the Public-Private Collaboration Act into health, and also encompasses other collaborations or engagements between the public and private sectors that necessarily don't fit into the act. So making that environment broader and encouraging more interactions between the two sectors. And maybe just to give some examples that are within the law, the PPP Act, their typical PPPs are one that was taken up by Makueni County Government, Phillips and Amref. And it was taking the form of equipping the primary healthcare facilities, and then they provide services. Different parties had different roles. Like I have mentioned, Amref was taking care of the community bit, Phillips was taking care of medical equipment, the government was taking care of policy, dialogue, and human resource. And they were able to realize that they increased uptake of primary healthcare services that were of quality. And as well, there was increase in enrollment to the National Hospital Insurance fund that we call NHIF in our insurance that we call NHIF in our country. So another example that I could quickly give that probably atypical is a development impact bond that is being spearheaded by Triggerize. The Triggerize is the implementer, and its main role is, or its objective is to help adolescent girls access sexual reproductive services that are of quality and they are within their reach. And we also have, in that same arrangement, we have CIF, that is an investor. We have the outcome pair, that is FCDO, and that project ran for 2 years, and it saw young girls, around 2,000 young girls access adolescent sexual reproductive health. This was initially done in private facilities only, and they have gotten some funding to scale that up, and it will even going to include public facilities. And this will help address some of the social health needs and achieve UHC goals. Thank you.
Thanks, Maureen. Recalling the conversation we've had around protecting populations against catastrophic health expenditures that would further plunge families into poverty. Now let us discuss health financing. Dr. Obita, in which ways is private-public partnership an effective and cost-effective funding mechanism for PHC? In 2 minutes, kindly.
Okay, thank you for that. I think probably to start off, I would say PPPs are not the solution to everything. There are unique circumstances that PPPs would give you value for money as you invest. If I approach it from a market perspective, PPPs do well in selective markets where you do have adequate demand for the service or products that you will be rolling out. And this is looked at from the transactions that would take place in that setting. If I use some examples of, let me use one that worked pretty well in Kenya. There, when you have a private party, so there was a PPP where you had Lancet come together with an NGO, WWF, and work with the national and county governments to be able to increase access to diagnostics in that region of the country that was in void. And so what ended up happening was that you had the private entity come in, put in investment in terms of infrastructure, equipment, was able to train staff and be able to carry out the diagnostic services at costs that would be equivalent or close to equivalent to what any other public facility would provide. So at that junction, you are able to get more diagnostic capacity from primary healthcare facilities that were in the region, or are able to also refer their samples for diagnostics. Providers in the same facilities were able to increase their diagnostic capacity and offer better quality of care. And if this was also translated to where Lancet was operating from the private sector fully, you would realize that PPP was able to reduce the costs of diagnostic services as you were able to visit a public provider to get these services. So, and I could also give other examples, but I chose this one to just show that there are PPPs that you can come into to be able to increase access to either primary care diagnostic services that would be lower than what you would access in commercial or other private sector in the same setting. and be able to achieve the goals of cost effectiveness and quality to healthcare services.
Thank you, Doc. Same question to you, David, in your setting. What example can you share with us?
Yeah, thank you. So I am a very practical person. As a businessman and health professional, I want to be very practical. So let's see the general truth. PHC, unless otherwise well-established and well-organized, a nation cannot achieve the universal health coverage or the SDG at the end of the 2030. Okay, so because of that, we have to work efficiently and effectively on PHC. But when it comes to PPP, unlike my colleagues in my neighboring countries, Ethiopia is very new for PPP. We just started. Maybe the credit goes to COVID pandemic. So in the PPP, what did we do? One of the things in the PHC, as you know, is earlier intervention. And that's the private was in partnership with public in mitigating COVID. Before it was like going to the countryside from the main cities and to major, highly populated areas. So, as you know, the government and was mainly focusing on three things: the venue, where to do it, how to do the testing, and then thirdly, how to get the supplies. And in these three components of the equation, the private sector was invited. And one of the biggest venues that was providing service for the when the COVID was announced in Ethiopia was a private facility, an arena that was accommodating 16,000 people, was erected, established, converted into a hospital. And then when the testing came, in fact, one of my colleagues, Dr. Marcos, is there, introduced an innovative system of checking COVID through having a drive-away system, whereby people will not get down from the car, but will pass through just like a McDonald's service and get their test, and then check their on their mobile and email. And then when it comes to the supply, the major problem was supplying oxygen to the public hospitals. And the private sector was having all the supplies of oxygen that time. And then what happened was the private sector was called upon to have a coordinated supply of oxygen throughout the country. And we, the private sector, were supplied. One of our company, my family business, is supplying oxygen. And we went into that business because we had a hospital out of town. And we used to get our oxygen prior to COVID from Addis, about 100 kilometers away where we are. And then because of that problem, to solve that problem, we got our own oxygen plant as a different business, okay? That was before COVID. Now when COVID came, we were one of the major suppliers of all this oxygen. So what did we do? The government, instead of putting oxygen generators in every major hospital and referral hospitals, and increasing their cost, we gave them an option of supplying them at a minimum cost to all their facilities. Post-COVID, fast forward 2022, what are we doing now? To minimize their cost. You see, if we minimize the cost of the service, then healthcare will be affordable. So what we are suggesting now and negotiating with the government is, instead of supplying oxygen gas, we're introducing to supply liquid oxygen. Out of a liter of liquid oxygen, you can fill the ordinary oxygen tanks, which are like 41 liters, 10 of them. So imagine with one truck of liquid oxygen, you can supply the whole hospitals in Ethiopia in just 2 days. So by that, we're trying to reduce the cost of at least oxygen. In that way, we are doing, our best to minimize the cost of health service so that it will be affordable at primary care healthcare service.
Absolutely impressive. For both of you, whatever you've shared, I'm just wondering, what do you see as the role of the other non-state actors, the parts in your country, the civil society? What role can they play in strengthening such mechanisms? And I'll go back to Dr. Bita for that.
Thanks for that question. So what the role of other NGOs and development partners would be on the financing mechanism, right? So probably I'd say that they do have a role from the demand side and the supply side. And probably from the demand, let me start with the supply side. Based on the challenges that you have on primary healthcare providers accessing, for example, capital, there are mechanisms that these financiers, these organizations can de-risk the credit that they're trying to seek. For example, to start up a very basic primary healthcare facility can cost you anywhere between $7,500 to even $10,000. If there are providers who are able to put in some proportion of that capital, and donors and development partners can de-risk and be able to enable this access to capital, then you can have proliferation of primary healthcare providers who can then even go further and create networks across different parts of the country, either be it in Kenya, be it in Uganda, be it in Rwanda, so that at the end of the day, you have primary healthcare facilities that are accessible to as many people as possible within, for example, even a 5-kilometer radius. So that's one. Secondly, on operations, helping in financing operations. You just had Nicole just mention about some of the financing mechanisms where you can be able to provide credit based on the transactions that take place in facilities that are going concern. So if you also do have NGOs or development partners who can facilitate this working capital for these providers so that they can be able to meet their current liabilities on supplies, on payroll, etc., then that also can be able to support these providers. From a demand side perspective, there are also innovative ways where demand side financing can be done for various populations, especially for the poor, where you can have matching funds, say with governments, to be able to provide financing for the very poor. So you can't come to you can't engage a government and say for your indigents and for your poor, we can be able to match certain proportions of financing for a certain population in a certain geographical location, and that's one form of use of the demand side financing.
Thank you, Doc. David, in 1 minute, please.
So again, here in Ethiopia, health insurance is one of the schemes that we're using to finance the PHC. The government is trying its level best in coordinating and also in encouraging healthcare insurances. Plus, there is this great opportunity coming to Ethiopia. Safaricom has started operation since last 2 weeks, its system in Ethiopia. So we are expecting new digitalized financing system will be in picture soon. And this, I hope, will bring more and effective kind of payment system whereby people will not have to have that cash money from their own pocket, but can be done through a credit system from, in conjunction with the private commercial banks. That is being introduced. And finally, we don't believe that the cost that we're having now in Ethiopia is really the true cost. Mainly, most of the government entities, as we know, are not that efficient. And because of the lack of efficiency, most of us are a little bit exaggerated when it comes to the charging. And the wastefulness is not that easy. So in conjunction with NGOs, what we have to do, I believe, is that to give a training on cost minimization and bringing efficiency to the workforce. Thank you very much.
Thank you so much. I'd like to come back to Dr. Kavanda. What lessons can we pick from private health sector in terms of digital and medical technology adaptations to increase access to primary healthcare? When Dr. Nicole was talking, she said that without digital and medical technology, UHC can be just but a perfect dream. So for us, for the countries in the region to realize our primary healthcare goals, all geared towards UHC, what can you say?
I think drawing lessons from what we've been doing in the health sector and also anchoring it on the principles of PHC and some of the core areas that we may need to focus on, which literally I think should form the grounding of that discussion, especially in line with how do I advance the PHC-related issues in the country or in countries to be able to advance disease prevention aspects in line with, for example, maybe in digitalization. And we know that one of the core areas for advancing PHC is in line with health literacy, trying to increase health literacy, and how best we can leverage on available digital technologies that we have. We have previously partnered with actually telecom companies in the country to be able to leverage on what they have, especially on electronic media, to be able to educate masses on health-related issues. Recently, COVID was one of them. But of course, also we know that the smartphone applications that are available now is one of the key areas that we can leverage on. And it's one of the areas that we have actually piloted, especially at a community level, through use of our community health workers, and realize that it's one of the key areas that we can use, including supporting our community health workers to be able to make preliminary prescriptions to their people in villages, and of course also trying to link patients at that level to healthcare facilities. It's one of the key areas. We have seen advancements also through use of digital technologies to advance telemedicine, and of course also telehealth. So these is mostly telemedicine. These are some of the key crucial areas which I think our countries need to advance, especially given the fact that we don't have many highly specialized health professionals. And if we are able to have discussions on equity, it's one of the key areas which I think that the digital technologies actually need to advance. Lastly, in line with access to health information, we have seen that currently the minority who have access to digital platforms actually influence the majority who don't have access to these platforms. So you realize that what the minority perceive from the digital platforms on health issues, it can influence the entire country. So leveraging on social media and these other digital platforms, I think, is one of the key areas which we have experienced and which we can advance as the sector.
Absolutely. So messaging, communication is key. And thanks for adding to the conversation that happened just before this panel discussion. I'm wondering, how can these solutions that as a region, we are not short of innovative solutions.
how can they be scaled up or how can they be integrated? And this would be a question that I'd like to direct to, let's start with Dr. Vito.
So is the question to scale these in the public sector or the private sector, or where you have a mixed health system? Or?
A mix, because we are talking about public-private.
Okay.
So you get to go, and then we also want to hear from the public side.
Okay. I think from some of the challenges that we have to scale innovations in the public sector that are from the private sector. One, when we consider the mechanism that some of these innovations can be financed within the public sector, what modalities are available from either existing PPPs as an example, either financing mechanisms, either from direct contracting, is it either from accreditation of these innovations so that they can be taken up into benefit packages that can be reimbursed when these are offered. That's one. So considering what financing mechanisms are there when determining these. Two, I think probably from the needs of the and demands of the public sector, how are innovators also engaging the public sector when they are at the design phase, when they are at when they're considering the business model? Because in some cases, the business model of the innovation is not designed to be absorbed by the public sector. So you end up having innovations that can only be implemented in the private sector. And when the conversation comes on how to scale it up in the public sector, then you do not have a business model for that. That's another thing. I think also looking at the further on the demands and the needs of various counties, countries, where are their priorities lying based on their national policies? Where is the government leading towards in terms of its